So I am really excited to do this simulation. We've done it several times. We started out with this with real live patients, and it was really cool. But as with everything that we've learned with the interprofessional education, working with students, then in order to reach more students, we need to do it by simulation. So we pulled it back and now we do it by sim. But the basics of why we do it and what we want people to learn are the same. So we're going to be looking at two different things. We're going to look at social determinants of health and how they impact your patient's health and well-being, obviously, what those are, how we assess for them, and what we might do to intervene, and the impact of knowing them has. And then, so next slide, please. And we'll also be, I'm moving to the next slide, but I also will just prime you. The other thing we're going to be talking about is health literacy. So two concepts that we're going to be looking at, and you're going to have some tools to use in the context of applying them to a patient with sepsis. So in the next few slides, we're going to talk about all of those concepts and then sepsis. The impact of social determinants of health, and by looking at everybody on here, you already have had some experience with healthcare. So you've probably seen this, but things that we look at for social determinants of health involve just money, economic stability. And one of the things that we know with that is that where a patient lives, their zip code, we'll talk about neighborhood in a minute, matters. And that's because it's generally a reflection of their economic stability. Their economic stability is based on their ability to work. So what kind of income do they have? It's based on their expenses, as we know, their debt, but it definitely correlates with their medical bills and their ability to, the old word is be compliant. We know that that's really not the word that we want to use with patients anymore, but their ability to just do what is suggested for them. One of the things that you'll see on a slide here in a second, but I don't think it ever hurts to reiterate it, is that, this is what we know, healthcare professionals, this little slice of people's lives when they come to us is what we know. It's 100% of what we apply. But for our patients, our impact on them only accounts for 20% of their overall health. 80% of their overall health and their outcomes and what's going to happen to them is related to everything else that's on this slide. And so knowing about those things and doing what we can do in our tiny little sliver that we get to work with them is one of the reasons why we're addressing this. And so we talked about neighborhood, obviously the kind of house that they live in. Do they have a house? Do they have housing that is something that they can rely on, or they are at risk in their housing? Again, we can't make assumptions when we're sending patients home, because this is our case as a patient who's discharging, that they even have running water, that they have the things that they would need to have to take care of themselves. Are they safe? Is safety a problem? And that comes into play if we're wanting them to be able to even pick up medications. Are they safe getting them? Do they have transportation to even get to appointments? And then what kinds of built environment is around them? If we're wanting people to be healthy and exercise, but they're not safe, they have no playgrounds, they have no sidewalks, they don't have anywhere to do that, walkability becomes an issue. And then education. And we know that those are all tied. So education, the level of education is not necessarily a direct indicator of the income, but it certainly is a backward way of looking at it, back door. Because generally the lower the education, the less paying jobs that people have. And so looking at their level of education is a way that we can kind of see those social determinants of health. And then literacy. And in this case, we're talking about literacy for healthcare literacy. But obviously, if they struggle with English as a language, then they're probably going to struggle with healthcare literacy as well. And then food. Again, knowing that we're just a sliver and knowing how important nutrition is. If our patient lives in a food desert, if our patient does not have access to good, healthy options, that's going to be a problem. And then the community in which they live, and this goes into social supports. What do they have? Who do they have? What kind of network around them is going to be able to help care for them? It's amazing, and I'm sure you all have seen this too. It's amazing what our patients discharge with. I mean, some of the things that our patients discharge with that we're expecting family members to take care of make us nervous as healthcare providers at times, depending on your experience with those particular things. But we're, see one, do one, there you go. And depending on what that community network is, what that provides, their social support is, that may really be a problem. And then the system. So healthcare system, do they even have a provider? And these are all things we're kind of look for and assess for today. We can't make an assumption that somebody has somebody who is going to continue to follow them. When we say, do this, follow up with this, call this person, making an assumption that they even have this person could be erroneous. Okay, next, please. So as we said, it's huge. It's huge. And this is just to reiterate what I said a few minutes ago, where this slide, which the first time I saw it, it was like, that's incredible. Because again, for us, we're there. This is our life. This is what we see. This is where we impact them. But realizing that truly 80% of what actually happens to them and what determines their health or their lack thereof is totally outside of us. But we can have a hand in that if we assess for it. If we assess for it and we take actions that help with those things. Okay, next, please. So how can we do that? Well, that's what we're here for today. So next. So, and this is just an example to kind of get people thinking about, even small things can fall into something that are social determinants of health and that we might be able to do something about. So in this example, it's looking at our colleagues who are in the dental business. So if you were a dental hygienist and and we know so much more now than we used to about how important the health of the mouth is to the overall health of the patient. But you have a patient and you ask them, like we all get asked, do you floss and brush twice a day? The patient and it's not always the case that we get somebody who's really honest with us, but the patient says, I ran out of floss and toothpaste after that I got on my last visit, and I can't afford to get more. It's a simple thing. It's a thing that happens time and time again, because for many of us, it might be, wow, that's not that expensive. But if you're barely making it through your day and barely meeting your needs, toothpaste and dental floss certainly aren't going to be high on your list of things to get. But there are resources for this patient. And so whichever your profession happens to be, whichever niche you're in, there's going to be an opportunity to enter into these social determinants of health and maybe make a difference. Okay, next. Okay. And so this is a screening tool, and this is one of the tools that you're going to use. So when we get done with the slides and you get ready to plan for your patient Joe, you're going to get some forms, and this is going to be one of them. This is an assessment tool. This tool has been built into the electronic medical record at OU Health, and it's built into quite a few medical records now in places where you go. But this is something that you're going to use, and you're going to ask these questions about, how are the social determinants of health impacting this patient? I want you to just kind of glance through these questions real quickly now and tell me, on a scale of 1 to 10, how comfortable do you think the majority of patients are answering these questions? And you can just unmute and say a number out. 1, they're not comfortable at all. 10, they're, oh yeah, sure, I can talk about my physical or emotional safety. What do you think?
I would say a 3 or a 4.
Okay. Any other thoughts?
I was going to say about a 5 in my experience at the hospital asking these questions.
Okay. Okay, good. Thank you, Todd and Kayla. I would agree with you. I would say in my experience, and when, like I said, we did this with real life patients when we first did it. We had one patient, his comfort level with this was about a -2. I mean, he was very angry when we came at him with these questions. I would say that Todd and Kayla are probably, most people, they may be uncomfortable. They're not going to have the intense reaction that that patient had with our team that day. But they're not going to be, most of us are not going to be necessarily comfortable being asked if we have enough money, essentially, or if our electric has been shut off. And so one of the things that I love about this simulation is that if you've not had a chance to do these types of forms with patients, with today, I think a lot of you have, but if you haven't, this is a really good opportunity to practice, because it may be uncomfortable for you to ask people these questions, even more so for your patient, but we have to figure out how to go in there with that elevator speech to help ground them and make this normalized for this conversation. The other thing that you'll talk about when you get ready, when you're having your 10 minutes to prep, is knowing what we just talked about. What's the order that you're going to do things with your patient? Are you going to lead with this? Are you going to lead with something else? Because knowing that something could cause strong emotions might change the way that you start your conversation. So patient education, I talked about the other concept that we're going to talk about today is health literacy. And one of the reasons why, we all feel so passionate about this is because really what we want to do when we talk about interprofessional teams, we all have to remind ourselves that the main person on our team is the patient. If 80% of what's going to happen to them happens with them out there, then they are the far more important person on the team than anybody else. But if they haven't been given information in a way that makes sense or that they can understand, they're not in a position to make good decisions. So that's why health literacy is so important. Okay, next. So health literacy, what does it do for us? It helps you find the right services and doctors. And then when you go to the doctors, it helps you learn how to manage your own chronic health conditions. If you don't understand even a tiny bit of why your blood sugar is going to go high when you eat certain things, it's going to be very difficult to be, the better word is adherent, or to maintain what you need to do to help with that. Get to the place and appointments they need to get. Figuring that out is actually part of health literacy. Where am I supposed to go and why am I going to that person? Taking medicine the right way. And I think we've probably all been in situations, again, looking at where you are in your programs and your careers, where we've done medication reconciliation and we find out somebody's on 3 different blood pressure medicines prescribed by maybe 3 different providers, and they're all targeting the same way of reducing our blood pressure. And so they're getting too much. They're getting too many that they don't know, they don't understand. This one was generic and this one's trade name and this one, so the health literacy as far as medications is critical. Filling out health forms and accessing their online record. Again, you can't make assumption that they're going to actually get the discharge material if we don't give it to them and they don't know how to use it. Sharing their medical history with their healthcare team. This one is huge. My 87-year-old mother is having some cardiovascular stuff going now. She's very cognitively fit. Everything's good. But listening to her hear her medical story from her perspective, there's gaps. Just so recognizing where are the pieces that maybe didn't make sense, so it's not in the narrative. And so one of the things that you'll do today is when you teach, getting people to respond back with, what happened? Why are you here? How does this fit? Because that's part of their medical history, their story. And if they don't understand it, they're not really going to be able to share it with a provider well. keeping up a healthy lifestyle, and then following advice. So all of those things are health literacy. And all of those things can be, we actually in our 20% are the most important people to help them with all of those things so that they can manage the 80% without us. Okay, next. So as we've said, this is just kind of saying it again, but what the data tells us is they are, without health literacy, the impacts of not having it, more likely to visit an emergency room because maybe they don't know how to pick providers. They don't know how to go to someone else. They don't have that stability, have more hospital stays because they don't understand why something happened in the first place. So therefore, how can they take action to make it not happen again? Are less likely to follow treatment plans because, again, they don't understand why they matter. And when they go to make decisions between this and that, they don't have good information and they die more. So they have higher mortality rates simply because they don't truly have the ability to understand and weigh everything to help them make decisions. Okay, next. So again, how can we help? And that's one of the reasons why we created this simulation. Next. So what we've talked about is getting the story. Part of getting the story that we have in healthcare is screening tools. That's how we get a bigger idea of what the patient is going through, what all of that 80%. Finding out what they understand about their diagnosis. If they don't know what got them here, it's going to be really hard to build on that. It's called scaffolding. If you really don't know what caused this problem in the first place, me telling you what you can do about it isn't going to make a whole lot of sense. Understanding about their medications. Why are they taking it? For what disease? What does this drug do? Certainly not in the intense level that we have, but enough to know, okay, this one is for this. This one's for this. Why are you giving me another one? Don't I have enough? And then clarification and education, which, like I've said, is what I have. I'm an oncology clinical nurse specialist, and for 12 years, I ran a high-risk clinic for breast cancer, did genetic counseling, and still do with Stevenson Cancer Center. It is amazing to me where you have to start sometimes to get people to have the basic information to understand what is going on and what matters in making decisions. But that's what we want to do. Okay, next. So these, we all love our acronyms. And this is one to help us remember how to help people get better health literacy. And it's called STEPS. So we want to speak slowly. I will say again, just because of my experience with my mom, you don't have to yell. Don't assume that they're hard of hearing just because somebody's older. And you don't want to speak slowly just because maybe English isn't their native language or that they're older. But speak slowly enough that a normal person would be able to comprehend what you're saying. Teach back. That's what I was talking about a minute ago. So if you really want to know, okay, I just taught, one of the things that you're going to do today is you're going to teach your patient how to take their pulse. One of the ways to see whether your teaching was effective is to ask them to tell you how to take a pulse. It's called a teach back. And that sounds simple, but that's a very easy way to find out. Encourage questions. I probably haven't stopped and asked if you had any questions enough, but that's something to do frequently when you're working with your patients. Does this make sense? Ask it whatever way feels comfortable to you. That's usually what I say. Did what I say make sense? Or did anything that I say cause confusion for you, cause fear for you, worry for you, anything like that? You're just wanting to know. And then show examples. We love stories. Stories cross the hemisphere of the brain. People learn better by stories than anything else. This lecturing that I'm doing is not nearly as much fun as stories. And so if you have examples, your patients will love those examples more than anything else, and they will remember what you've given them by giving examples. Like I said, I'm an oncology nurse. I used to teach all of my brand new patients about the side effects of their chemotherapy not only what they might expect, but what they're going to do about it. And so early on in my career, I had a patient tell me a story about, so usually if the drugs are going to cause complete alopecia, hair loss, they do them between about 7 to 14 days after their first dose. That's what I would tell people. I would tell them your hair is going to start thinning, and then one day it's all just going to, between that window, it's going to be there, and then it's not. It's going to be really rapid when it starts. These are some of the things you can do. Well, I had a patient who came back to me after her hair had fallen out, and she said what she did is when she was in that window, she went to the hairdresser. She did not tell her hairdresser that she had got chemo or that her hair was thinning or that she was in this window. She waited until the hairdresser was washing her hair in the basin, and it all started falling out. And then she got up and she was yelling about what did the hairdresser use on her hair to cause all of her hair to fall out. My patient thought this was hilarious. She knew all along. The hairdresser, it's a good thing, did not have a heart problem, because I don't know how she would have handled that. And all of the other people getting their hair cut or getting their hair washed right then in that salon. When I heard that story from her, I was like, okay, not only was this an amazing story, I'm a little worried about you now, and I hope that I never make you angry. I hope that you always think I'm a good nurse. But it also really gave me a story that I could give other patients. I'm like, okay, here's what I want you to do. If you want to shave it off, shave it off. If you want to get a wig, get a wig. We're going to do this. But please do not go to your hairdresser. Please don't do that to someone else. So that story, I think, reinforces the information that if I had just sat there and said, this is what I want you to do, they might have never remembered. Okay, next, please. So in the following slides, we're going to talk about what you're going to use today. And we're going to talk a little bit about sepsis too. So we're going to talk about why you're going to use it and what you're going to use. Okay, next. So for health literacy, we already talked about the social determinants of health tool that you're going to use. For health literacy, this is also a tool that you're going to use today. And when you break into your groups, you're going to pick which one you're going to do. So there should be enough tools and enough of you that you can say, okay, who's going to ask these questions of your patient? And this is going to help you determine the best way to teach Joe. Okay, next. And this is another one, I just mentioned it. One of the things that you're going to be teaching your patient, she is a patient who was septic. We're going to be teaching her things that we hope she'll be able to do to be a partner with us to let us know if she sees signs of sepsis coming back. So you're going to teach her how to take her pulse. Okay, next. Okay, and we're doing all of this because, like I said, we don't want to be paternalistic. That's a lot of patients, a lot of people actually seem to prefer us to be paternalistic. Tell them, just tell me what you want me to do. And that's an easy thing to do, but it doesn't create any understanding for that patient. It doesn't make them a part of the team. It just says, here, do this. It's a lecture. It's not a story. Where we want to go is all the way down on the end where it says we want to make them a partner, because they are a partner. If 80% of what happens to them for their healthcare is totally unrelated to us, they have to be a partner. So we want them in this circle, and we want them guiding the team. Okay, next. And this is just to reiterate that point, but with cuter little figures. But in this one of the things I love about this one is that it says that our partnership of care becomes an actor of care. Our patient is an actor of care. And that is true, whether they're acting for the good of their care or the bad of their care. They're still an actor in their care. Again, far more than we are. And so making sure that we give them the information and support that they need to meet their healthcare goals. How are they going to take action on this? Okay, next. So the last thing before we get to the fun part, the simulation part, is, okay, so We're taking those two concepts, health literacy and social determinants of health, and applying it to a patient with sepsis. Why are we applying it to a patient with sepsis? Because sepsis is a huge problem and actually has some decent, not good, decent recidivism. So people with sepsis once have a risk of having sepsis again, and there are things we can do about it. And I think all of you probably have been introduced to sepsis, probably taken care of patients with sepsis. But just as a reminder, the number one thing about sort of curing sepsis and making it not happen again is to know what started it. Back to that sort of health literacy for us. What's the source? Where is the infection coming from? If we can't figure that out, or we can't do something to keep it from recurring, then that's a problem. And then knowing when we're at risk for it, knowing. So if we're sending somebody home with sepsis and we know that there's an increased risk of repeat sepsis, and we don't tell them what to do if they see, or how even to recognize if it's coming back, then we haven't really taught them. We're not making them an actor in their team. And then as we see, the things that can cause organ dysfunction, which leads to death. Okay, next. So what this data tells us, the reason again, why this was really started anchoring on sepsis, more than 19% of sepsis survivors are readmitted within 30 days. So they don't just have sepsis, go home and be done. There's a pretty good chunk of them that will come back. Of those, a third of them will happen within 7 days of discharge, which means that there were probably things when they discharged that were clues, and certainly things that we could give them, arm them to try to reduce that. One study found that 42% of readmissions for severe sepsis occurred based on a diagnosis that could have been potentially prevented. And so back to the source. What's causing this? Back to our patient without the toothbrush and the floss. If our patient has an abscess and that's the source of their sepsis, and they do not have the means to have the abscess treated, and maybe an assumption is made, go to see this dentist, get this abscess taken care of so that you don't repeat. They can't do that because they don't have the money, they don't have transportation, etc. They're going to return with sepsis. It accounts for 700 deaths per 2 minutes in the US. Sepsis is one of the leading causes of death and disability in the world. It is a huge problem wherever we go. And again, our older patients, our patients that have chronic issues, of those diagnosed with severe sepsis or septic shock, 40% died in the hospital within a week of discharge. 75% died within 3 years. If 75% of 700 people per 2 minutes die within 3 years, but we might be able to do something to help them, then all the time we're spending today is worth it. Okay, next. So this is our history, and I will let Vanessa take over now.
All right, thank you, Dr. Kraft. So our brief history. So Joe was recently in a motor vehicle accident and was admitted to the hospital after sustaining a significant injury to the leg. Post-surgery, Joe had a surgical wound infection that led to sepsis. After receiving appropriate treatment and stabilization, Joe's condition is now improved and Joe is ready for discharge. So your simulation objectives. So you'll have to, when you go into your sim, you'll be able to prepare by meeting with your team, and you'll have 10 minutes to decide what you all will be doing. I'm going to send you some documents, and then you'll be able to review it with your team so you can decide which documents you want to review and go over with your patient. So you introduce the team and explain the situation to your patient. You'll prepare Joe for discharge by doing the following: explain and complete the health literacy screening tool with Joe, explain and complete the how to check your heart rate tool with Joe, explain and complete the sepsis stoplight tool with Joe. Throughout, assess Joe's understanding of the material using the steps method previously discussed. And then, as Dr. Kraft said, you're able to share your screen with your patient so they can see what questions are coming up, or just so they can have like a view of what you're teaching them.